Good afternoon and welcome to the Alliance for Home Health Quality and Innovation's Learning Collaborative webinar on home health federal legislative developments, reimbursement, post-acute care reform, public perception, and more. My name is Teresa Lee, and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. As many of you know, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients and the entire U.S. healthcare system. Today's webinar is part of the Alliance's Learning Collaborative series. The Learning Collaborative webinars seek to offer information and perspective in addressing healthcare delivery system change and reform. The webinar today will focus on home health federal legislative challenges and opportunities. The impetus for this webinar grew out of interest from Alliance members on our Quality and Innovation Working Group. These members expressed to me the need to ensure that we have a strong understanding of the federal policy environment to inform the home health community's future work to prepare for changes in the healthcare delivery system. The Alliance has contributed to the policy conversation involving bundled payments by commissioning the Bundling and Coordinating Post-Acute Care, or BACPAC, toolkit and analysis. However, interest in post-acute care has been evolving. This webinar is meant to offer an overview of the federal legislative trends that will influence home health care and the healthcare system writ large so that we can be informed of how the policy environment is shifting. Before I introduce our speaker, I want to thank and acknowledge the leadership of the national and state home care organizations representing and advocating for home health care. In particular, in Washington, D.C., the National Association for Home Care and Hospice, NAC, the Visiting Nurse Associations of America, VNAA, and the Partnership for Quality Home Health Care organize and lead the home health care community in advocacy and policy initiatives at the federal level. NAC and VNAA and the state associations further provide a tremendous array of educational, training, and quality improvement offerings for home health providers. The Alliance is pleased to work with these fine organizations to provide research and education on the value of home health care and appreciates the synergies that we enjoy with all of these organizations. We should all be thankful for their leadership and tenacity on behalf of the home health care community. Now I'd like to introduce our speaker, who we're very fortunate to have. Eric Berger serves as the CEO of the Partnership for Quality Home Health Care. Prior to joining the partnership, he served as the Senior Vice President for Public Policy and Communications for DaVita, a Fortune 500 kidney care provider, and as Vice President of Government Relations and Public Policy for U.S. Oncology. Previously, Eric served on the professional staff of the Commerce Committee of the U.S. House of Representatives, where he developed Medicare, Medicaid, health insurance, and other reform legislation. Before his service as a congressional staffer, he served as Virginia's Legislative and Policy Director for Health and Human Resources, where he helped to develop Virginia's welfare reform legislation. Just a few housekeeping notes before we get started. First, Eric will present for approximately 40 minutes and will leave the last 15 minutes for discussion and Q&A. Please note that this is a webinar and we control the slides on our end, so please do not be surprised if you cannot flip ahead. Second, your lines will be on mute, but please do submit questions through the Fuse webinar software on your computers or other devices during the presentation so that Eric can address some questions as we go. You can send a question to the speaker by sending a question to me, Teresa Lee. Finally, we will be posting the slides on the Alliance website after this webinar, and we are also recording the webinar and will post the playback on the Alliance's website. Without further ado, I'd like to turn this over to Eric Berger.
Thanks very much, Teresa, and thanks everybody for taking the time to join today's webinar. I would like to add one additional piece to my background. It's one I'm particularly proud of, and that is that I have the privilege of serving on the board for the Alliance and can attest to the terrific work that the Alliance does. So, Teresa, thank you for all that you and Jennifer do, and the fellow board members, and of course for the opportunity to join you today. Why don't we go to the next slide? By way of brief background of the partnership, our membership spans leaders from across the home health care community. So you can see they include Alacare, Amedisys, Bayada, CareSouth, Encompass, Gentiva, Great Lakes Caring, Guardian, LHC Group, and VNA Health Group. Our purpose, as stated on this slide, is to develop and advance innovative solutions to strengthen the Medicare home health benefit, its quality, efficiency, integrity, and very importantly, its sustainability for the sector as a whole, and most importantly, for the many beneficiaries who depend upon it. You can learn more about the partnership at our website, which is www.homehealth4, that's the number 4, america.org. Why don't we move on to our first content slide. So as the topic of this webinar indicated, we're going to be covering not only opportunities facing the home health care sector, but also the challenges. And let's start with those challenges because certainly they are occupying a lot of discussion these days. I intentionally chose dark clouds as a way of illustrating this, but I do want to introduce the concept right up front that there is a tremendous amount for us to be positive about, some great opportunities that lie ahead. We're going to be spending the bulk of our discussion today focusing on them. But first, as it relates to the challenges, certainly the Affordable Care Act and subsequent implementation by CMS has posed significant challenge to home health care providers across the country, and as a result to the Medicare beneficiaries who depend upon home health care at home. On a proportional basis, the cuts that were suffered by the home health care sector were the largest of any sector in the Affordable Care Act, and we are seeing the effect of those cuts every single day. Rebasing is only the most recent example of that, but it's not the last one. Productivity adjustments face us on January 1st, and so we will be continuing to grapple with the implications of this legislation on the services that we provide for years to come. That is quite clearly a very serious challenge. So too is the continued discussion about reimposition of a copayment. We've seen this topic come up time after time on Capitol Hill, in MedPAC recommendations, and including in the President's budget. It is of concern because, of course, as we all know, there used to be a copayment in the Medicare home health benefit, beginning with the inception of the Medicare program itself. Congress saw fit to repeal it in 1972 because by that time they had real-world data that was having a very negative effect on the poor seniors who were depending upon health care at home. Were causing many of them to go into facilities instead for care, causing even greater costs to be borne by the Medicare program. That history is something that not everybody on Capitol Hill is aware of. It's one of the things we've been working to do, is to make sure that they are fully cognizant of that fact. And for reasons we'll discuss in a moment, we do believe that the challenge posed by the copayment is beginning to dissipate, but we must remain on guard, as it would be a very, very bad step for the poor seniors who depend upon home health care. Fraud is another challenge that faces us. There is and has long been a perception that fraud and abuse are rife throughout the home health care sector. That, of course, is not true. There are isolated instances of fraudulent activity, and we know this because Medicare data itself documents that fact. So that, too, is a challenge that we face to ensure that perceptions concerning fraud and abuse are fully informed, and that those who are justifiably concerned about fraud and abuse in the home health benefit, as in any component of the Medicare program, recognize that the vast majority of providers throughout this program, throughout this benefit, are compliant, ethical, hardworking, and doing the right thing by beneficiaries and taxpayers. And again, we'll return to that too in a moment. Finally, there are concerns with respect to value. And here we have a real dichotomy in place. Increasingly, we are hearing decision makers make the point that they recognize that home health care plays a very important role in Medicare and has real value to offer as structural reforms that we'll talk about momentarily are contemplated. At the same time, there's also concern that providers in the sector are not themselves delivering value. That's a challenge we have to overcome, and data is the way for us to do so. And we'll come back to that as well in a moment. But first, let's talk a little bit about the opportunities on the next slide. Program savings would seem to be an odd item to include in a slide focused on opportunities, but it really is a key one. We are dealing with an era of constrained resources, not just in Medicare, but across the federal government. And as a result, within Medicare, decision makers are working very hard to find ways to make the program do more for an ever-increasing number of beneficiaries with fewer dollars. Home health care has an opportunity to play a critical role in that for the very reason that we are the lowest cost setting available to seniors in the Medicare program. How we can best deliver the savings that would come from treating more seniors in the dignity and the safety of their home is an opportunity that we'll discuss shortly and that lies before us this year and beyond. Structural reform is the means by which, of course, that opportunity might best be achieved. And there are a number of proposals already on the table, and more still to come, that would modify the manner in which Medicare covers services, particularly to chronically ill seniors. And one common theme amongst many of those proposals is an increased role for home health care. And part of that, going to the next item here, is due to the fact that increasingly policymakers are looking at the homebound restriction that is currently a part of the Medicare benefit and finding that it may be an archaic component of the Medicare program. That rather than limit access to health care at home solely to those seniors whose physicians have documented that they are homebound, limits the access that other seniors would otherwise have to such services, and therefore compels them to receive services that they need in often more expensive facilities. The Veterans Administration has pointed the way that the Medicare program may ultimately follow. Home-based primary care program within the VA is an exciting program, but it is by no means a new one. It's been around since 1972. It has fast become the most popular of all health programs within the VA, and it is responsible, according to VA data, for substantial reductions in cost simply by enabling more seniors to receive quality services in their own home. How we can achieve these opportunities is itself an opportunity, and that is being recognized as a trusted partner by policymakers and decision makers across the spectrum, including on Capitol Hill, in MedPAC, in CMS, at the state level and beyond. What we'll do next is talk about some of the particular issues that have been challenges and how we're best addressing them as a community, and some that lie before us. So why don't we go to the next slide. Certainly the threats of cuts and copayment, as mentioned before, have been annual events. We've seen proposals for across-the-board cuts from everything from the super committee to congressional budget lists to the president's budget to MedPAC recommendations, CBO budget option books, and beyond. Tough to go a month or two without seeing some new mention of another market basket cut or the reimposition of a copayment. How best to address that? Well, one of the strategies that we've found to be very effective relates to helping educate decision makers about fraud and abuse. Why? Simply because in many decision makers' mind, more cuts and a copayment are needed because there is, in their view, excess utilization. So therefore, the thinking is, if we reduce the economics or force seniors to bear an additional cost for the care that they're receiving, that utilization, which they deem to be excessive, will be tempered. This is where it's critically important that we help decision makers understand just how isolated the aberrant behavior is that justifiably concerns them. One of the tools that we've found to be very helpful is this map. We didn't author this. This is, of course, MedPAC's map. And what you see here are the 25 counties out of the 3,143 counties and county equivalents across the country that MedPAC has identified as having the most excessive utilization of episodes. what we've been able to do with this map, and this is just an illustrative tool from a pretty vast toolbox, is to go to decision makers, go to lawmakers, go to agency officials, and be able to say, is it appropriate that ethical providers in your state, in your district congresswoman, in your state senator, should be forced to suffer yet another cut, or that the retired school teachers that you represent should be forced to bear additional out-of-pocket cost in order to address a real problem that exists a real distance away? And as you might expect, the answer has been, no, that makes no sense at all. What else can we do? Well, what else we can do is something we'll talk about again in a little bit, and that's strengthen the home health benefit with improved program integrity safeguards that target the isolated problem without imposing greater harm to the delivery system as a whole. We've been able to join with other leading advocates in making this type of a message, this type of an appeal to decision makers. A coalition has been formed called Fight Fraud First, which, as you might expect from its name, has a pretty simple message, which is before a single dollar is taken out of a beneficiary's pocket, or another dollar is taken from the benefit on which they depend, every dollar that can be recouped or prevented to be spent for fraud and abuse should be. And that has been a truly resonant message, and it has enabled us to be able to say that as of today, no home health cuts have been passed since the Affordable Care Act was enacted, and co-payments are increasingly losing favor. Another aspect of this is helping decision makers understand the vulnerability of the beneficiaries who would be impacted by this. Thanks to data analyses by Avalere Health and Dobson DaVanzo, which are available on our website, we've been able to help decision makers learn that seniors who are receiving home health care services are, this is Medicare data, older, sicker, poorer, more likely to be disabled, more likely to be minority, and more likely to be female than all other Medicare beneficiaries combined. And that, too, has helped us turn some attention away from across-the-board harm to more targeted solutions. Why don't we go to the next slide? Another critical strategy in dealing with some of the challenges that we face is engagement with CMS in a constructive fashion. And this is something that's incumbent upon all of us throughout the community, and it truly does depend upon data. We are a big believer in data. As a former committee staffer, I used to joke with people who came to see me that the dollar bill may say, "In God we trust," but you better have data. I take that to heart. And we work very hard with NOC, VNA, the state associations, and others to develop the strongest data set possible to inform decision making. Also critical is engaging the beneficiaries that we're privileged to serve, their family members, of course their caregivers, and the broader grassroots. And we've been proud to partner with others to launch Bring the Vote Home, which is a voter registration and absentee ballot drive to ensure that all folks who are served by the home health benefit have the fullest opportunity to participate in the democratic process. And you can learn more about that at bringthevotehome.org. As a result of this type of an effort, the data, the community engagement, grassroots education, participation, and the like, we were able to actually have a an additional case mix cut that was proposed in 2012 for implementation in 2013 removed. It was a 0.86% case mix adjustment. It would have reduced Medicare funding for home health care by an additional $200 million last year. And instead, as a result of all the engagement, reconsideration was given to that case mix adjustment, and it was taken out of the proposed rule. And as a result, the community and the beneficiaries that it serves were spared from that cut. Why don't we go to the next slide? Another good example of the benefits of positive constructive engagement is, ironically, this rebasing rule. I say ironically because this rule continues to be a very, very tough one to read, certainly even tougher still to live with. Seeing the maximum allowable cut under the Affordable Care Act implemented through this rule is not anything that anybody in the community who worked so hard in the rulemaking process expected. And yet, of course, that is what the final rule does decree. One key component, however, was changed. We were able to determine, looking at the proposed rule, that CMS was incorrectly, in our view, interpreting the statute. And as a result, they were applying the rebasing adjustment to 2013 value as opposed to 2010 per the statute. It doesn't seem like a big deal, but the delta between those two was a bit over $1.8 billion as an impact to the sector as a whole just over the 4 years in which rebasing would be implemented. It was a dramatic impact, a little over $22 an episode. What you see here in that scroll is an excerpt straight out of the final rule. And it is both a welcome thing to see and instructive that the administration, the secretary, the general counsel's office, and the like, having been of one mind on this issue in the beginning, heard the comments, reviewed the data, reviewed the legal analyses that were presented, and recognized that their interpretation had been incorrect, and they modified it. And again, that itself resulted in a rebasing adjustment that would have been $22 an episode worse than it is today, being corrected. So where do we go from here? Let's go to the next slide. Rebasing, of course, continues to be a challenge. Every single day we're hearing about more impact that agencies are suffering as a result of this unprecedented 14% cut. Now again, the Affordable Care Act did allow the Secretary to impose such a cut. The language that was included in the legislation gave the Secretary discretion to establish a rebasing adjustment that couldn't be any greater than a 14% increase or worse than a 14% cut over 4 years. It was certainly hoped that the worst case scenario would not come to pass, but that is what is currently in regulation today. And so there is an increasing conversation about readdressing that impact, readdressing that decision. And the manner in which that is being examined is severalfold. Certainly there's a growing conversation throughout the community and beyond. There's been increasing media attention to this issue. For those of you who watch Fox News, Special Report with Bret Baier aired 2 segments a few weeks back specifically on home health care rebasing. And the consolidated clip of those 2 segments is shown in this slide. In addition to that, folks are coming together to have community conversations about this. And the platform that supports those conversations can be found at savehomehealth.org. Lawmakers of both parties and in both chambers continue to be speaking about this because, of course, as folks on this phone call know, over 200 members of Congress engaged in the rulemaking process and asked the Secretary not to impose that full 14% cut. One of the reasons why we believe that cut was finally implemented is because data analysis that would have informed the decision and we believe would have led to a more moderated outcome doesn't appear to have been conducted. The Small Business Administration sought a regulatory flexibility analysis since more than 90% of all home health agencies fall below the SBA's definition of a small business. It doesn't appear that the Reg Flex analysis was done. That's an important piece of data. In addition, the President has an executive order. It's number 13563, and that requires that any regulation with a substantial economic impact, as this one was decreed to have, be subjected to a cumulative impact analysis. That too doesn't appear to have been done. And of course, very importantly, an analysis of the impact of rebasing in each of the 4 years in which it is being imposed does not appear to have been done either. According to the rulemaking, only 2014 was assessed. But even that analysis is troubling because, as CMS said in the final rule, it estimates that 40% of all home health agencies will be driven into net loss by 2017 as a result of rebasing. And so there is a conversation going on now about providing relief for home health agencies who are struggling as a result of rebasing and reassessing the rule as a result of the Regulatory Flexibility Act, the President's executive order, and an assessment of its impact over each of the 4 years. Certainly, we're supportive of that and are hopeful that the Secretary will undertake that reassessment with a particular focus of the impact of rebasing on states, and particularly their medically underserved areas within those states, rural communities where counties might be served by only single home health agencies, by the seniors, who, again, Medicare data demonstrates are older, poorer, sicker than all other Medicare beneficiaries combined, on women. And this is a real significant issue for women, not only because the majority of home health beneficiaries are women, but as you know, of course, the vast majority of home health providers and the vast majority of family caregivers who manage an elderly parent's care and elderly relative's care are women. And finally, and importantly, of course, on jobs. We have already seen, and the partnership just issued a statement yesterday relating to this, that rebasing has already had a dramatic effect on what historically has been a robust job creation engine. Looking at the 10 years, the 120 months that preceded the issuance of the rebasing rule, our sector generated, on average, nearly 5.5% annualized growth rate in jobs, nearly 500,000 jobs over that period of time. In December, 3,100 jobs were lost. That was the first month following the announcement of the rule, and it was the single largest loss of jobs in our sector in over a decade. But it was soon surpassed because in February we lost 3,800 jobs. So we are now seeing an annualized growth rate that is less than 1/4 of what it used to be. Real impact as a result of this rule, and it certainly seems to underscore what CMS itself projected, that approximately 40% of all agencies would suffer net losses as a result of it. So relief and reassessment are one of those opportunities because an increasing chorus of voices are calling for it on the Hill and off. Why don't we move on to the next slide? I mentioned before program integrity protections, and this is a discussion of some of the ideas that are out there. This is by no means the full universe of possible solutions. It's been a very exciting thing to see this community come together and work in various different capacities on a lot of different ideas, all of which have the same common theme, which is how do we best strengthen this benefit so that not a single dollar goes to anybody who doesn't have the best interest of the beneficiary at heart. And what we've been working on as a partnership is something we call SHIPS, or the Skilled Home Healthcare Integrity and Program Savings Proposal. We've been talking certainly to folks on Capitol Hill about this. It continues to be something we believe is necessary, kind of regardless of whatever else is going on. It includes a variety of different safeguards that are listed here in the box. The bottom line is that we believe, based upon the successful precedent of the outlier limit that the community proposed in 2009 and was implemented by CMS January 1, 2010 and included in the Affordable Care Act, that real tangible changes can be built into the benefit that would prevent the expenditure of dollars for anything other than services delivered to seniors. And we found that to be already an effective tool through the outlier limit, which has achieved an over 70% reduction in the spend in that particular type of claim by eliminating fraud and abuse within it. And we believe that similar safeguards can strengthen the benefit as a whole. Importantly, it also helps decision makers to recognize again that the problems that concern them are isolated and the solutions that they should be focused on are targeted, as opposed to across-the-board cuts or a copayment. But we'll move to the next slide. Post-acute care reform, as Teresa mentioned at the outset, is, of course, a hot topic these days, and it's been building for some time. We've been seeing a growing conversation informed in large part by the hard work that MedPAC has been doing on this, by the bundled demonstrations that CMS has been implementing under the Affordable Care Act, by the leadership of a number of members of Congress, again, both parties, both chambers. We've been seeing different proposals being put out there. Just an example of the work that's going into this, and I'll then talk about where it might be leading, are the Better Care and Lower Cost Act. And that was recently introduced by Senators Wyden and Isaacson and Representatives Paulson and Welch. That legislation, for those who are not familiar with it, it is very much worth a review. Again, it's the Better Care, Lower Cost Act. It's focused on improving care coordination for Medicare beneficiaries with multiple chronic conditions. And the focus that they bring to this is the use of multidisciplinary healthcare teams. Now, this is not surprising from the author of the Independence at Home Act, that he, of course, being Chairman Wyden, continues to be focused on this very positive direction for Medicare. In fact, this is legislation the partnership was proud to endorse. The legislation creates the Better Care Program. And what that would do is that would allow health plans as well as groups of providers to form better care plans and better care practices. They're both called BCPs. Now, this is voluntary, of course, but what it would enable plans and providers who choose to participate in it to do would be to receive capitated risk-adjusted payments. And the purpose of those payments, as opposed to the status quo type of payment, is that it would reward better health outcomes for those beneficiaries who participate in the program. And those better health care outcomes would be achieved through improved care coordination. Again, a critical component of the reform discussion that's well underway right now. Some of the other reforms that are being discussed include the Comprehensive Care Payment Innovation Act. And this is a PAC plus hospital bundling proposal that Congresswoman Diane Black and Congressman Richard Neal introduced recently. This would create bundled payments within the Medicare program. It would include the inpatient payment as well as the post-acute care payment. And it would be involving qualified entities who would be operating within it, each of which, and they could group themselves any way they wanted, but there would have to be a hospital no matter what grouping that they had. And so it would be a combination of what we see inpatient and post-acute care in the form of a bundle. Again, a very important component of the conversation that's underway. Another proposal that's in development is something that we've had the privilege of working on as well, and that's the Bundling and Coordinating Post-Acute Care Proposal, or BACPAC. Now, this is born directly from some of the really landmark work that the Alliance has been undertaking. The Alliance's CASEP analysis, which stands for Clinically Appropriate and Cost-Effective Care, extraordinary work done by Dobson DaVanzo Associates for the Alliance, documented something that, of course, we've long anecdotally known, but now have quantifiable evidence to point to, and that's what's illustrated here on this slide. And that is that patients who were discharged from a hospital who received similar services in the hospital, they were classified under the same DRG, and who have very similar clinical characteristics, are seeing varying different costs depending upon which setting they go to. In other words, what we don't currently have in place is rational distribution of patients post-discharge to ensure that patients are receiving the clinically appropriate care they need in the most cost-effective setting. The BACPAC plan is somewhat similar to Congresswoman Black's and Congressman Neal's plan in the sense that it would create a post-acute care bundle, but in this instance it would solely be a post-acute care bundle. It would not include the inpatient payment, and it would not be controlled by the hospitals. Instead, it would create a parallel structure in the post-acute care world to the DRG system that we see inpatient. And in that regard, our view is, and this is speaking solely for the partnership, that it would allow for, it would secure patient choice. They'd be able to go to any of the providers that they wish rather than those that might be within the same group that their hospital was a member or controlled, and it would enable for savings to be achieved by ensuring that the care that was delivered was in that clinically appropriate, cost-effective setting. So we were excited about that proposal and expect to see that coming out shortly. In addition to all of that, of course, is the work that the key committees have been working on. Energy and Commerce has been actively engaged in BACPAC. The Ways and Means Committee and the Senate Finance Committee have been very much engaged in something called the IMPACT Act, and that stands for Improving Medicare Post-Acute Care Transformation Act. It's a great acronym. And what this is a result of a process that the committees made available to stakeholders last year. Many of the folks on this webinar may have participated in it. Certainly the partnership did, the Alliance did, and many others as well. And that was an open door, if you will, for people to submit their ideas about structural reform to the committees. They received ideas from over 70 stakeholders, and the committee sorted through all of that, and no small task, and came up with the IMPACT Act, which establishes the means by which standardized data will be developed. And of course, standardized data is critical so that there can be a comparison of quality across PAC settings, improvement of discharge planning, and the reform of PAC payments. There's a timetable associated with that, and of course that is being assessed along with the different bundling models and the care coordination proposal that Senator Wyden and others have put forward, all as part of a conversation that I said at the outset is really gaining quite a bit of steam these days. Where do we see this going? What we really see is in the future, we're going to be seeing some significant action by Congress and the administration on structural reform that could really mean significant change, not solely within the home health care benefit, but well beyond. This has been something that's been talked about for a while, but in light of the proposals that are coming forward now, we believe that 2015 may be the year in which reforms of these types might actually see legislative action and implementation subsequently begun. We're very excited about it. It will require everybody in our community, folks on this webinar and beyond, to be very heavily engaged in this to ensure that the decisions that are made are fully informed and best support seniors' access to quality care. But already the steps that we're seeing taken towards a world in which the silos that currently exist within Medicare are broken down, where seniors are able to get the care that they need in the best setting for them, and where restrictions like homebound are waived in order to make home-based care available to more seniors. These are all very exciting indicators of the kind of reform that could be coming in quite short order. Why don't we move to the next slide? One of the components of this discussion about structural reform is value-based purchasing. We just saw an element of value-based purchasing passed by Congress as part of the SGR legislation that was just completed. That related to the skilled nursing facility sector, and it pertains specifically to rehospitalization rates. But as those of you who may have seen yesterday's article in Healthcare Finance News know, it is by no means an issue that is limited solely to the SNF sector. If you haven't seen it, there's a good article in Healthcare Finance News dated the 7th, and the headline is Home Health on Road to Reducing Readmits. And what it talks about is the fact that the conversation concerning readmission reduction and other elements of improved value are very much in people's minds. There's a good quote here, and I'll actually read it because I thought it was very well said. Barbara McCann, of course, at Interim, was quoted as saying, "This is a message," meaning the work that's being done in value-based purchasing. "This is a message to the industry that we are joining the rest of the system with accountability. That is important, and if you can't perform, there will likely be fallout for you." And that, of course, is the intention. What Congress and the administration are looking to do is to ensure that providers reach to the next higher level bar in terms of performance, that they deliver the best quality they possibly can, the maximum value they possibly can, not solely to taxpayers, but importantly to beneficiaries. And so incumbent upon all of us in the community is not only to participate in that conversation, but also to develop comprehensive data that can help inform the discussions that are already underway. Key data points are listed here on the slide, but it's by no means limited to solely these points. Bottom line is that there is a real attention being given to achieving improved value through payment reform that achieves better outcomes for beneficiaries in the program, and that in turn such attention will be in lieu of across-the-board cuts or other aspects of what I call the blunt force trauma school of public policy making. So we are seeing already value-based purchasing really moving forward, and we expect that we will be seeing even more of that throughout this year and into next year. Well, we move to the next slide. So to wrap up, and then allow time for questions if anybody has any, just some concluding thoughts here. I recognize that there are a lot of folks out in the community who are certainly worried about the impact that we're suffering as a result of legislation and regulations that are already in place, and certainly worried about threats and challenges that face us, and they're right to be. Our community has suffered greatly from, as I write here, misunderstanding about the nature of and value of home health care, negative perceptions, not solely about fraud and abuse, but oftentimes relating to aberrant behavior, and of course the deep legislative and regulatory cuts that we have experienced. As I point out here, and this is something that we at the partnership believe very strongly, the fault for these decisions not only rests with those who make them, but rather we all have accountability for those decisions. And it's incumbent upon us, therefore, to do everything that we can to build strong, constructive partnerships with decision makers and deliver to them the quality data and policy ideas that they need and really are looking for from all of us. So there is a lot to be worried about, but there's also a lot to look forward to and a lot to be excited about. The data analysis that's been underway and is already serving to inform decision making, the kind of constructive relationships that are in place and are growing stronger every day, and the new ideas that folks throughout this community are putting forward have already had a real impact. Again, I would point out there hasn't been a new home health care cut passed by Congress since the Affordable Care Act. That's an important statement. It's a sign that this community is having an effect. The future will be far more positive still than just the prevention of harm, because what we are seeing ahead are real opportunities for transformation within the Medicare program that could make the quality, the dignity, the safety of receiving healthcare services at home available to a broader population of seniors who would be achieving and realizing an even higher level of value and better outcomes as a result of that. These are all possibilities that are right before us and will be achieved with the constructive engagement from the community. And I'd be remiss if I didn't repeat what Teresa said at the outset in my closing, and that is that positive outcome is incumbent, or does depend, I guess I should say, on our community. Working together, all the major organizations, the state associations, the grassroots, individual providers, and thought leaders throughout the community, we can affect real change. We've already begun to see evidence of that. And so we're very excited about what the future can bring and are proud of the role that the partnership is playing in that. We stand as a resource to anybody and look forward to anybody reaching out to us if you've got any questions. The next slide has my email address. And certainly if you've got any questions for me or would like to make contact, please feel free to do so. But in the meantime, Teresa, I'd be more than happy to take any questions that might have come in.
That's terrific. Thank you so much. What a great presentation, and absolutely appreciate the time and energy you've spent with us today to give us that very fine overview. I want to invite everybody on the call to please submit your questions via the Fuse webinar in-meeting chat box, and I can read the questions as they come in. But while we're waiting for that to queue up, I wanted to just say, sort of thinking about sort of connecting the dots on all of the changes that we're seeing in the legislative environment, and try to contextualize it a little bit. Eric, your friend and mine, Blair Childs from Premier, he presented at the VNA annual meeting last week. Some of you on the phone may have been there. And he did a really nice presentation sort of about the Affordable Care Act and trying to connect the dots on what all of these healthcare delivery system reforms are really driving toward. And, he made the point that basically, you have multiple different initiatives, and of course it was from the hospital standpoint, but basically he characterized all of these healthcare delivery system reforms being about trying to drive us toward a value-based system that cuts across silos rather than one that's traditional and fee-for-service, and that, track one on that path are sort of the reforms like value-based purchasing and the penalty for readmissions. And track two are sort of the broader sweeping demoed reforms, things like ACOs and bundled payments. And so I was thinking as you were talking, and tell me what you think, that when we think about home health care, they're getting to us just a little bit later than they're getting to the hospitals, I think, in the sense that we don't have value-based purchasing yet, but as you put it, it might be on the horizon. And then maybe the next step after that is, those steps towards things like bundling, or maybe it's sort of, as you put it, from the Wyden legislation, sort of capitated, coordinated care payments for those with multiple chronic conditions. So anyway, I just thought I would, sort of put that out there and tell me what you think about, how those dots are sort of connecting.
No, I agree. The dots are certainly connected. At its essence is, as Blair said, value. And what is value? I mean, loosely defined, it's above average outcomes delivered at below average cost. That's really what decision makers are looking at. And they're right to do so, because they're not just decision makers, they're payers. They want to be sure that what they're buying on behalf of the millions of beneficiaries participating in this program are the best possible outcomes at the lowest possible cost. Would anybody accuse the Medicare program today of achieving that outcome? No. There's a lot of improvement that's obviously needed throughout Medicare, not solely within our benefit. So what they're looking at doing are cross-silo, as you pointed out, reforms that will institute both within benefits and across benefits changes, micro as well as macro, that will all lead to the same outcome: better outcomes at reduced cost. It is the only way that this program is going to be sustainable for the long term. And that's why you see some of these interesting proposals out there, as well as some of the initiatives that are already underway through CMMI. What they're working to do is to test various different ideas and approaches. And in the end, what will be the Medicare program of the future is one that doesn't look like the one today. It will not be a series of silos that isolate patients depending upon where they happen to land. And there will not be payment devoid of accountability, as Barbara put it. But instead, we're going to see patients go, as the analysis that the Alliance put out, Teresa, to the most clinically appropriate setting. They'll receive far better care coordination, and the cost will be far lower than it otherwise would have been under the system that we know today. That is a reality. It has to be, just by virtue of the increasing number of seniors entering the Medicare program and, of course, the cost burden that the program is bearing. But that's why, as I mentioned before, that's not only a real challenge for decision makers, but a terrific opportunity for home health care if we step up to it.
I couldn't agree with you more, and I wonder too, as we get more towards those reforms that are getting at cutting through the silos, to what extent do you think we'll also have opportunities to reform the way the home health care benefit is today, and might be geared better in the future in the context of things like, maybe for certain types of patients, getting rid of homebound so we're able to provide, longitudinal continuous care effectively.
Well, in the MedPAC meeting last week, they were speaking about the elimination of homebound, so that's very telling. But beyond that, I think what you're seeing in some of the proposals is that this elimination of the silos, the bundling of care, will enable seniors who wish and are able to stay home to be able to do so, irrespective of their mobility, and enabling seniors who want to be able to be at home but do have real clinical needs to have those needs met in a setting that not only is the lowest cost, but also is the one that they most strongly prefer. And that's where we get into some of the interesting variety within the ideas. The idea that certainly Blair, I'm sure, may have spoken to, and certainly has been one that is being talked about, a bundling that includes the hospital stay as well as the post-acute care stay, does concern many folks within the post-acute care arena, not solely within the home health care sector, but beyond, out of concern that there may be more vertical integration that would occur, and therefore patient choice may suffer. What we would hope for is that there would be post-acute care bundling that would be specific to the post-acute care sector, bringing together SNF and IRF and LTAC and home health care, and enabling physicians and patients to be able to make decisions and coordinate care in the best settings, in the best manner possible. That's certainly something that we think has great resonance, and we'll see how the conversation plays out over the course of the year.
That's great. So I've got a question here from This comes from Beth Hennessy from Sutter, and she asks, in addition to the 30-day and 90-day hospitalization metrics, what other key outcome measures should home health providers focus on collecting to further demonstrate our value as partners? And I do think this is sort of anticipating, in the direction of the Senate Finance and Ways and Means discussion draft that they shared, the Impact Act draft. So I'm wondering if you have picked up in your interactions, or any trends and interest in terms of what quality metrics you think are going to be important for home health to try to develop or work with CMS to develop.
We have, and Jen, I wonder if you can go back a few slides to the value-based purchasing slide. But there, the box there has a number of the factors. Wow, that was fast. A number of the factors that we've been hearing from folks, not only on the Hill and in the administration, but in MedPAC and beyond, that they're really looking at. Examples would include spend per beneficiary, number of visits per episode, number of episodes per beneficiary, and beyond. What they're really looking to determine is the variety in the care that's being brought out, that's being delivered, and an assessment as to what is the right number. And that's very, very tricky. How do you determine what is the right number of, the spending per beneficiary or visits per episode or episodes per Benny or beyond? That's the conversation we have to be a part of. But in the end, that is where they're going to land. Value-based purchasing, after all, is really governed by a decision as to what is the optimal outcome, and then payment that either rewards or penalizes depending upon one's performance relative to that metric. So one of the things that we're doing at the partnership is a very deep dive into this data to determine what our experience has been on these and other key data points. It's definitely an exercise we'd encourage everybody throughout the community to do, because this is the data that decision makers are hungry for, and they're looking for us to deliver it. If we don't, they'll make decisions that aren't benefiting them from our information. It's not like they're going to pause. So really important opportunity for us to take advantage of.
I think that's true, and it's great to see. Thank you for laying this out. I think it's also incumbent upon us to think about what are the metrics that are really needed to make sure that we're achieving patient-centered care, and patient engagement, and making sure that what we're being held to makes sense from both a home health provider perspective and from a patient perspective. And so I think it will be important for us to look really closely at these data points and make sure they're the right ones too.
Exactly.
And you're right, it'll be telling. I think we'll be held to these, and regardless of what we're held to, it will say something. So we want to make sure that it's, we're finding the right metrics so that, we're gearing it in the right direction. So it's helpful. I'm not seeing any further questions here in the in-meeting chat box. I'm wondering if you have any final thoughts, Eric. I'm also thinking that, as I'm trying to connect the dots to that, I wonder to what extent policymakers are thinking of the rebasing cuts and how it's sort of connecting up with healthcare delivery system reform. I mean, do you think that they're thinking about things like payment accuracy, and that this is their pathway to that? I mean, I know it's absolutely going to be incumbent upon us to try to document things like access issues, but I wonder if that's the way they're thinking about it.
It's a fantastic question. What we've been experiencing in our conversation with lawmakers and staff about rebasing is a real, I can't say awakening, but certainly an expanded awareness of the home healthcare beneficiary population and the care that needs to be taken in developing and implementing policy relating to them. The data analysis that I referenced earlier concerning the actual nature of the beneficiary population, I can't emphasize enough how impactful that's been in our conversations. Anecdotally, of course, we've known this is a very vulnerable beneficiary population, and there have been various different pieces of information that have been used to try to make that clear, and yet certainly I've run across many on the Hill who don't have a true sense, a real sense, as to what the home health care beneficiary population is, what the human face of the beneficiary population is. And so therefore there's been some uncertainty. I've only been with this community now for a little over 3 years. So for me, it was kind of a great opportunity to approach it the way a lot of folks on the Hill, frankly, approach it, which is to say I didn't have a lot of information, and I tried to pick up as much as I could. What I was troubled to find is that a lot of folks on the Hill didn't have a very clear idea as to what home health care is, period. And secondly, the true vulnerability of the beneficiary that depends on it. The data that Avalere and Dobson-DaVanzo have developed is dynamite. Again, working solely with Medicare data, so it's absolutely verifiable. They've documented that the Medicare home health beneficiary population is older, poorer, sicker, more likely to be disabled, minority, and female than all other Medicare beneficiaries, and the numbers aren't even close. We've got those materials on our website. What I would encourage everybody to do is, in all of your conversations with decision makers, help them first understand who it is that they're really talking about. What is the nature of this beneficiary population? What is the nature of the care that they're receiving? And absent the receiving that care at home, where would they end up? As lawmakers have been getting that keen awareness, they've become much more sensitive to the implications of public policy, including but not limited to rebasing. And so I think, in an ironic sense, the trauma that has been visited upon home health care as a result of that final rebasing rule is actually having one beneficial impact, and that is it is certainly serving to inform a lot of decision makers that greater care, greater data analysis needs to be undertaken before other changes are placed upon this benefit, because they're seeing the nature of the population that's been impacted and the real impact that this particular cut is already having.
That's great. Thank you for that. And I think we've got maybe time for one more question. And this one comes from Andrew Awani from Access, and he's got a question about whether there's been any discussion about initiatives like hospital at home, which I think is distinguishable from home health care, and that it's more like hospital care provided in the home, and how maybe some of those higher intensity models of care might fit into things like bundled payment arrangements and legislative policy discussions, in your opinion.
Sure. Well, those ideas have gotten a lot of traction as well. I did not mean to exclude them in focusing purely on bundling because they've been running alongside for quite a long time as well. I would expect that we're going to see a lot more discussion about that too over the course of the remainder of this year. Again, I don't expect that we'll see much in the way of legislative action on any of these items just by virtue of the nature of the remainder of the calendar this year. But next year looks to be, it seems to have all the hallmarks of a reconciliation year. Of course, that could change, but what I mean by that is we could see Congress undertake sweeping budget legislation, as they've done in the past under those very specific budget reconciliation rules. When they operate in that manner, significant changes are possible. And so I think what we'll see in the conversations that are going on right now about hospital at home and, of course, different bundle types initiatives and value-based purchasing and the like is they're all going to come to a head maybe around springtime of next year, perhaps as Congress revisits SGR or perhaps as part of broader reconciliation legislation. The election will certainly have something to say about that, but I think we're going to be seeing quite a lot of activity and change before the end of the next 18 months.
I think that's a perfect way to wrap up because, I'm Chinese and, the Chinese character for crisis is both, chaos and opportunities. So, I think that basically is what we're looking at in the legislative environment as well. So with that, I want to thank you, Eric, for that lovely presentation today. And as I mentioned at the top of the hour, we have recorded this webinar. We're going to try to get the recording up on our website as soon as we can. We'll also post Eric's slides right away. It'll be on the public portion of our website so that folks will be able to have access to it. And if any of you have any questions, you can direct them to Eric. His email is in the slides, or you can contact either me or Jennifer Schiller. And with that, I hope that all of you have a really wonderful afternoon. Thank you.